as we are developing new therapies for patients with AML, MDS, myeloid neoplasms in general, I think we're understanding how do we use them, where do we see their benefit, and also what impact does that have in the overall health system. And one of those ways we can think about it is the economic burden of treatment. If our goal is to decrease the amount of visits that a patient has to have and decrease the amount of infections that they have, that should translate into a decreased economic burden. And so this is a surrogate way of analyzing how does the intensity of treatment and the resource utilization of treatment change when people get diagnosed versus as we try to maintain their or consolidate their treatment response and then keeping people on maintenance. And so in this paper, we analyzed different phases of treatment using a claims database to try to understand what costs were associated with people during their initial remission induction, what costs were associated with people when they were trying to consolidate that remission, and then what the cost of maintaining that response was, and comparing that also to when they relapse, what happens to costs. And so perhaps as expected, we found that induction was a fairly expensive, high utilization period of treatment. We also found that relapse results in a high amount of treatment utilization. And what we also describe is that really when you have a response and you're maintaining that response with therapy, the longer you're on that, you have deeper, lower costs of care. And so if we can take the therapies that we're discovering and create longer periods of maybe maintenance type therapy, but less intensive, less time in the clinic, less time getting infections, but remaining in quality response, we can both achieve benefit for our patients, but also reduce the overall cost that the treatment is impacting the health system compared to when we initially have to treat them at diagnosis or when their disease relapses.